This is Brian Wormers recording a lecture on care of patients with infectious respiratory problems. Our main learning objectives with this are going to be apply principles of infection control, of course with any patient, but especially those with respiratory infections. We're going to describe diagnostic testing for people with suspected respiratory infections. We're going to talk about pneumonia, TB, and influenza, on what are some of the priority nursing diagnoses, as well as interventions for this. We're going to talk about identifying those patients at risk for respiratory infections, and then teach patients about personal actions to maintain health. So influenza is a very common thing, but it's often called lots of different things. A lot of people say they got the flu when they've got a GI bug, or they've got this, that, and the other thing, and they blame influenza on it. True influenza is a respiratory component. Ten. Go sit down. 10. Sit. Poppy, stop. 10. Sit. Be nice to each other, you doofuses. So this highly contagious viral infection can occur at any age. We do see it in infants all the way up through the elderly. It's not really dependent on race or geographic area or anything like that, and it can go worldwide, and there's lots of different strains of this and lots of different types of this. So some of the major complications include pneumonia or death, especially in immunocompromised patients, or anybody very young or very old. Symptoms, they just don't feel good. They're going to have a cough, they're going to be really tired, they're going to be really weak, really achy, fevers, chills. Oftentimes, it's kind of the traditional viral type of thing where 7 to 10 days later, then they start feeling better. So with influenza, there are a few things that we can do. Of course, planning prevention is always the best thing we can do. So getting the flu vaccine and on an annual basis is paramount for those people that are at risk, and I would say just even the general population, to try and protect those people that are at risk. Washing hands, having good cough hygiene, so coughing into your elbow. If you're sick, try to avoid being around people, trying to prevent that spread, using hand sanitizers, all those kind of things. When you're in the hospital, of course, this is BSI, so wearing the gowns, gloves, masks, protecting yourself, and in doing so, you're protecting your other patients as well. So we can talk about the nasal spray, but that's been discontinued this last year for lack of effect. Most of the time we're doing shots right now. There are some contraindications to doing those shots, such as if you've ever had Guillain-Barré, or some of the shots have got an egg component in them, so that might be a contraindication depending on which type of shot you're using. But the big thing is just trying to reduce that spread. We can give antiviral therapy if it's early enough onset, usually within 24 hours of initial signs and symptoms, which is sometimes hard and difficult to achieve. But if that's the case, we can give stuff such as like a Tamiflu and help them out with that. Otherwise, it's all supportive therapies with this. It's rest, it's increasing PO intake and fluid, make sure that they're hydrated enough and give them enough sleep, and just oftentimes let them be in a quiet environment. Sometimes they can get a little photophobic, or even loud noises can disturb them. Not like with the meningitis type of situation, but sometimes just things can annoy them. So just let them rest and hydrate them up in supportive care. So moving on to pneumonia, this can also affect all patients of all ages and demographics. This is an inflammatory process within that interstitial space of your lungs, and it impairs your gas exchange. So health promotion, disease prevention measures are paramount with this. We can give vaccinations to try and help those people that have got immunocompromised or that are elderly, and that's the pneumovax. When you talk about hand washing, good hand hygiene with the sanitizers and things. And then if people are on ventilators, we've got that whole um, Zap the Vap bundles, things keeping the head of the bed up, suctioning frequently, good oral cares are all there to try and prevent pneumonias. So assessments, what does this look like? So subjectively, patients will have uh, some shortness of breath and difficulty in breathing. We can look for a history of risk factors. So risk factors for pneumonia would be other infections, like we said, influenza can lead into this, or other viral infections can then subsequently turn into a pneumonia with secondary bacterial infections. We can talk about using drugs and alcohol and smoking. We can talk about having ventilator tubes. We can talk about chronic respiratory problems. CF is a big thing. So objective data is they could have flushed cheeks, nervous, anxious. If you can't breathe, oftentimes you're very anxious about that. Oftentimes they can have chest pain where that pneumonia is at. They can have a fever and just feel weak. They can have a cough. They can be bringing stuff up, such as sputum. It's usually multicolored, so tans and yellows and greens and different things like that. They can get chest weakness, especially if they've been coughing a lot. They can have crackles or wheezes in their lungs with diminished lung sounds. If you've got a big area of atelectasis and an area that's impinged by all this fluid and bacteria, it'll often sound dull when you percuss on it, or when you're listening to it, it's going to be diminished severely. This can also lead into orthostatic hypotension related to vasodilatation and dehydration. Some lab testing you may want to do would be an ABG, looking for how well they're oxygenating. You can get IgE levels if you're afraid that this is related to an allergic asthma type of a situation. You can get sputum culture trying to identify the bacterium that's in there. This can be from suctioning, or if they're able to bring up secretions, then you can culture that. Get a CBC, looking at that WBC to see if they've got an elevated white blood cell count. We can look at possible blood cultures to see if this is spreading into the bloodstream and to see if they're septic. We can look at electrolyte for imbalances related to fluid shifts. And then we can look at BUN creatinine if there's significant dehydration and it's affecting the kidneys. Other diagnostics would be imaging. So chest x-ray is probably the most common and it's probably one of the best for finding pneumonias. You can get more invasive by doing CTs and different MRIs if you really needed to, but oftentimes those type of images are not needed to diagnose a simple pneumonia. Other things would be pulse oximetry, looking to see what their oxygenation status is doing, and we can do aspirations. This is very rare. Planning and implementation. So we can look at nursing diagnosis. So of course we're going to be at risk for impaired gas exchange. Our goal, of course, is to have them breathing well without labor and having SATs greater than 95% and maintaining their level of consciousness without cyanosis. Interventions, give them oxygen with this. Do incentive spirometry, trying to encourage them to breathe, as well as coughing, turning frequently, and using those deep breathings. Another nursing diagnosis, risk for airway obstruction. With pneumonia, they can plug off airways. And so with that, we want to make sure that they're breathing effectively, they've got a cough, that they are acyanotic, and that their stats are, generally speaking, above 93% or 95% in this slide. Interventions, of course, would be cough, turn, deep breathe, at least every 2 hours, if not more frequently. I've seen some people get ordered every hour. Increase PO fluid intake to make sure that they stay hydrated. We're going to use bronchodilators sometimes. I've seen some contraindications on this, saying that if you open up those bronchioles, then the pneumonia can seed deeper into the lungs. So be careful with that one a little bit. If they've got lots of wheezing, a bronchodilator may be prescribed, but it's not going to be prescribed in all people with pneumonia. IV steroids can be ordered just to decrease any inflammation in the lungs. And of course, we'll be talking about, if it's a bacterial, we're going to talk about antibiotics, and then we can talk about expectorants, helping them to rid the secretions out of their lungs. We also worry about risks for sepsis with this, having it cross into the blood barrier or into the bloodstream. And so we really want them not to do this. So our goal is to prevent that and make sure that they're perfusing well and having a good oxygenation. Interventions for this. So of course, it's going to be an anti-infective. So this is antibiotics, antifungals, antivirals rarely, and then treating them with that to try and prevent anything that's in that bloodstream. So if taking as outpatient, make sure that they complete the doses, make sure that they're using those meds as prescribed, they don't stop them once they feel better. Tell them to come back if their symptoms are worsening, and then try to get them to avoid crowds and other irritants. So crowds so they don't get other people sick, and other irritants because it might make it worse. So an NCLEX challenge for this one. So if you're caring for an 89-year-old patient admitted with pneumonia, has an IV of normal saline running at 100 mils per hour, and antibiotics are initiated 3 days ago. Currently, oxygen is at 2 liters per nasal cannula. And so what assessment findings by the nurse indicates the goal for a priority diagnosis have been met? So 1, patient is alert and oriented to person, place, and time. 2, blood pressure is within normal limits in the patient's baseline. C, skin behind the ears demonstrates no redness or irritation. And D, urine output has been greater than 30 mils per hour per Foley catheter. So the first one that I would probably say is that A is probably your correct answer, because you're perfusing well and you're oxygenating well, and that's a huge component for this. Of course, you want good blood pressure to be within normal limits. It doesn't say anything that his blood pressure was off with this. Skin behind the ears demonstrate no redness. I'm not sure what this would be in regards to. Honestly, maybe from the nasal cannula. Taking a wild guess, but this would not be my answer. And then urine output, once again, I would want there to be good urine output with everybody. In an 80-year-old patient, I'd be really worried about having a Foley catheter in though, so I'd want that out as soon as possible. So my answer would be A, making sure that they're alert and oriented to person, place, and time, showing good oxygenation and no decreased level of consciousness. All right, I'm going to pause this one right here, and then there will be a part 2 in which we'll cover tuberculosis.